Shafiq is a good friend of mine and a brilliant colleague in Cleveland Clinic. He's a consultant pulmonologist, where we work closely together. Prior to joining Cleveland Clinic, Dr. Shafiq served as a consultant in respiratory medicine at Leamington New Forest Hospital, Southampton in the UK, where he also held the post of clinical service director. He also served as an honorary consultant at the University Hospital Southampton in the adult cystic fibrosis unit. Dr. Shafiq was graduated from the Punjab Medical College in Pakistan and continued his postgraduate training in the UK at the Royal College of Physicians, London, where he gained his MRCP. He holds a certificate of completion of training in respiratory and general medicine, and he has also completed a clinical fellowship in adult fibrosis at Southampton General Hospital, UK, and he's our cystic fibrosis expert in Cleveland Clinic. So without further ado, Dr. Shafiq, the floor is yours. Because it was supposed to be Hello. Now, yeah. You can just clip it. Right. Okay, so let's continue. I'm going to be talking about the tools we use for diagnosis of the allergic airway disease, which is mainly asthma, for all essential purposes. I'll be talking about spirometry, which is the most commonly used tool, bronchial provocation testing, peak flow meters, pheno, and I've put some question marks in front of oscillometry. It's a relatively new technique. I have never worked in a place where I had oscillometry, but I know at least one clinic in Abu Dhabi that's using it. So if any colleagues are using oscillometry regularly, they can actually enlighten me on that as well. I'm going to be using a few simple cases as props to discuss these investigations. So without further ado, let's get started. The first case is a 38-year-old woman with a history of intermittent shortness of breath for the last 2 years. She also has a dry cough. Symptoms often worse in the night. And she has been given Ventolin by a general practitioner using about 2 to 3 times per day. She smokes shisha about once or twice a week, and the symptoms are often worsened by the viral infections. The first thing I want to do is one tool that I haven't discussed in the list of the tools before is the clinical history, and that's I'm very passionate about that because we keep getting patients who are on asthma treatments when they don't really have asthma. So it's really important to try and tease out the symptoms associated with asthma. Wheeze, shortness of breath, cough, chest tightness are all symptoms of asthma. And then we need to make sure we ask about the history of variability. The variability can be seasonal in patients who have mild intermittent seasonal asthma. It can be diurnal in most patients. It could be related to their triggers when they're exposed to the things they're allergic to or smoke, etc. Or in a lot of cases, it could be exercise related. I would like to impress that not being able to take deep enough breath is not a symptom of asthma. Similarly, clinically, on the basis of history, we should be able to differentiate between panic attacks and hyperventilation versus asthma, because generally what starts happening is people go to the GP with anxiety symptoms, are given an inhaler which exacerbates their anxiety-related symptoms because it gives them more palpitations and handshakes, and then they go back. So the person who'd given them the inhaler puts them on the next step of treatment, and soon they are at a very high level of treatment without having the correct diagnosis. The other symptoms to look out for are things which coexist with asthma or which can exacerbate it. So allergic rhinitis and eczema, pets at home, smoking exposure, childhood asthma or eczema, travel history is important, occupational exposures in patients who have exposure to industrial dust or fumes at work. Similarly, chronic rhinosinusitis, gastroesophageal reflux, obesity, anxiety, depression, and use of beta blockers and aspirin and non-steroidals are all known comorbid conditions which can make your asthma control worse. So our patient was waking up with cough most nights, wheezed during the daytime when exposed to passive smoking or dust in the air, not able to swim for long due to chest tightness, no pets at home, works in an office-based environment, so doesn't really have any occupational exposure. So the history is very typical of asthma. So the next logical step is try and confirm it. On the day of the examination, the chest examination was normal, and her X-ray was also normal, maybe slightly on the hyperinflated side, but well within normal limits still. So this is her spirometry. Fairly obvious here. FEV1 is significantly reduced down to 61%. The ratio of FEV1 to FVC is very obstructive at 55%. And this patient had 53% reversibility to salbutamol. Is the diagnosis established? Let's see. What does Gina say? To diagnose, you have to have the symptoms of asthma, and you can use spirometry with reversibility, and FEV1 increased by 12% or 200 ml post bronchodilator is diagnostic. Greater confidence in the diagnosis if the increase is 50% or more than 400 ml. So there clearly is a good diagnosis here. I've put the definition for COPD there as well as per the GOLD guidelines, because whenever we are investigating obstructive disease, the main differential is COPD. And in COPD, there will be suboptimal bronchodilator response or no response. And there is obstruction in form of reduced FEV1 to FVC ratio of below 70%. When doing spirometry, it's very important to input all the parameters related with patient's age, height, sex, and ethnic origin, because the predictive values change hugely, especially the height and the age change the predictive values very, very significantly. There had been a lot of different predictive values available in the past, but recently the Global Lung Function Initiative has released a consensus guideline along with the values that we can all use and should be using. So they are easily available online if you have a portable spirometer which does not give these automatically. So there are many different types of spirometers. The bellows spirometers measure the volume. There's a bellows inside the spirometer. They are the oldest spirometers available. I have a few pictures in a minute to show. Most of the spirometers these days are electronic desktop spirometers. They use a windmill to measure the flow and then estimate the volume from that. And now in the last 10 to 15 years, we have a lot of handheld devices coming on the market, which can be used at home as well if needed. So this is the old Vitalograph, which is a bellows spirometer. I haven't seen one in UAE, but we have used it a lot in NHS in UK, and there's a lot of these hanging about. So this one has a bellows which inflates when you blow into it. It only draws a flow time volume curve over here, and then the operator has to calculate the FEV1 from that themselves, and then you have to look at the charts and calculate the percentage of the predicted. So there's a little bit of work to do by the person doing the spirometry with these ones. Very few of these are around these days. Most of the spirometers now are flow measuring spirometers. This is again an old picture, but the principle is the same. These spirometers have a windmill in the handset, and knowing the diameter of the tube and the speed of the windmill, it calculates the flow. And the important thing about these desktop spirometers is they give you the visual representation of the spirometry as well, which is quite useful for a number of reasons, which we'll discuss in a minute. More and more, we're seeing the smaller versions of the windmill spirometers, which can be used on desktop. We have that in our clinic available, but we have completely handheld spirometers now, which you can plug in to your computer with a USB, and it will give you the graphs as well. Or you can connect with, there are certain spirometers which you can connect with your smartphone now, and you can do longitudinal graphs over a period of time. So what are the uses of spirometry? Well, we want to differentiate between the obstructive and the restrictive disease, first of all, if there is a disease. And then in terms of asthma, it is used to make diagnosis and assess the severity of the disease. In some situations, it can be used to monitor disease at home, although for asthma, I think there are much cheaper alternatives to using a spirometer at home. It is used to assess the fitness to fly, fitness to dive, and for many pre-employment checks as well. So this is a video of our own desktop spirometer. Generally, before the patient starts, you can see that there is a line here, and it says ATS. So that's a 6-second line. If a patient blows up to there, then that means that the spirometry has met the ATS criteria. If they are shorter than that, then it usually is not a reliable reading. Let's see if this video works. No. Can we make the video work? No. Okay, sorry. It was a video of the spirometry actually being performed, but it appears that it's not working. So what parameters we get from the spirometry? FEV1 is the most important one when it comes to the obstructive airways disease. And that's the forced expiratory flow in the first second. So this is the volume time loop on the left side. And on that, when we see on the first second, we can see that most of the volume in the lung we expel within the first minute. And then FVC is the total amount of the volume we expel after a complete inspiration. On the left is a flow volume loop, which has an inspiratory curve and then an expiratory curve. For all intensive purposes, when looking for the obstructive and the restrictive lung diseases, we only focus on the expiratory loop of the flow volume loop, because that's where we see the changes in the shape of the loop. The reason why the graphs are important apart from the numbers is that once you look at them, number one, in clinic, you can straight away tell if this was a reliable reading or if it wasn't a reliable reading. You might have someone who, when you look at the FEV1 and FVC readings recorded, you might think this patient has severe restriction. And then you look at the time volume loop and it goes like this. The patient has only blown out for about 2.5 seconds. So that's not a reliable spirometry. You cannot make a diagnosis on the basis of that spirometric reading. The spirometry generally falls into 4 different patterns: the normal, obstructive, restrictive, or a mixed obstructive and restrictive picture. The normality is if the FEV1 and FVC are more than 80% predicted, and if the FVC to FEV1 to FVC ratio is more than 70%. So this is a volume time curve, and that's what it looks like in a normal patient. Most of the volume is expired within the first second. In an obstructive patient, there's much prolonged expiration, and here you can see that the FEV1 is very, very significantly reduced. So this hump of the volume time curve disappears. Compare it with the restrictive disease. So in obstructive disease, as we see, the hump has disappeared. It's a much more flatter curve. In the restrictive diseases, we see that the shape is maintained, but the curve is much, much smaller. And then in the mixed diseases, it depends on which obstructive or the restricted disease is predominant, and the shape of the curve will be determined by that. So it's It's important to differentiate between the shapes of the curves here. And similarly, we can use the expiratory loop of the flow volume curve to decide whether the disease is obstructive or restrictive. In restrictive disease, again, the shape is maintained, but the curve generally has less area or less volume in it. In obstructive disease, we see this concave hallowing of the expiratory loop. In the severe obstructive disease, it almost looks like a church spire. The reason this expiratory flow is reduced in the obstructive diseases is that in the obstructive diseases, we have significant dynamic airflow obstruction. So when we expire, the intrathoracic pressure increases, which presses on the alveolus. But the same pressure is also pressing on the respiratory bronchioles as well. In the normal healthy conditions, there is a balance and we have enough flow to continue to have a forceful expiration. But in disease conditions, the obstructive pressure increases significantly to reduce the flow during a forceful expiration, giving us that characteristic appearance of the expiratory loop of the flow volume curve. So this is a simple algorithm for someone who's not very accustomed to using spirometry and how to go about diagnosing obstructive diseases. Number one, is the FEV1 to FVC ratio below 70%? If yes, then that is an obstructive disease. Is the FVC low as well? If yes, then probably, I would say probably there is restriction or mixed restriction or obstruction. I said probably because in severe obstructive diseases where there's a lot of air trapping, you can have low FVC without having a restrictive disease there. If there is FVC is normal, then it's a pure obstructive lung disease. And then you do the reversibility testing. If there is reversibility, then you suspect asthma. And if there is no reversibility, it probably is COPD. It's very important to know how to do the reversibility testing if you are in a clinic where it's available. The challenges that we usually use are salbutamol, terbutaline, or ipratropium. Almost 99% of the times it is salbutamol, unless patient has some tachyarrhythmia, which precludes use of that. Both salbutamol and terbutaline, once you've had them inhaled, you wait 15 minutes before doing the second test. For ipratropium, it's a much slower acting anticholinergic, so you wait 45 minutes before doing the reversibility testing. The protocols for using nebulized medications are not standardized, but I know a lot of institutions use them, including our own, when the patient cannot use the inhaler properly. But it is preferred to use inhalers with the spacer instead of the nebulizers for bronchodilation. We need to withhold bronchodilators prior to testing. So the short-acting beta-agonist you can hold for 6 hours. Longer-acting, that is salbutamol and formoterol for 12 hours. The newer longer-acting agents like indectrol and vilanterol, you should hold for at least 24 hours. Ipratropium for 6 hours. And for tiotropium, again, you need to wait for at least 24 hours before doing the testing. Ideally, a patient should not have been smoking for at least 30 minutes before performing the test. If you have a lung function lab and the proper spirometry setup, then there is a requirement for daily calibration of the system using a 3 ml syringe. If you are a JCI accredited institution, you probably are already doing it and keeping all the records. If you're somewhere where there's an aspiration to do so, then it will be required. However, that's not needed for the handheld spirometers, which are different in the way they work. Instead of having the windmill or the bellows measuring the airflow or volume, they usually use the ultrasonic sensors, which do not need regular calibration. Which leads us to the question, these handheld devices, which are becoming very popular, are they any good? Well, there is data to show that they are as good as the spirometers we use in clinics. And I show 2 studies here. The top one is an asthma patient, more than 700 asthma patients over the age of 12. And the study showed the patients did both the handheld and the clinic spirometry regularly, and there was very good correlation between the two. And you can see the Spearman R here is 0.84, which means good correlation. There was less variability between the home measurements compared to the clinic. I'm not sure why is that, but obviously the home spirometry is good. In COPD patients with severe airflow obstruction, FEV1 less than 50%. Again, good agreement between the clinic-based and the home spirometry results. Home-based results were about 50 ml below the clinic values. That is what I've found generally with the handheld spirometers, that the values are slightly lower than the clinic ones, which in my opinion probably are because there's not a respiratory therapist pushing the patient to push hard enough. The suggestion that the home spirometry might be able to pick up exacerbations prior to onset of clinical symptoms in COPD. We don't have evidence for that in asthma yet. But certainly if a patient has access to a handheld spirometer, that is good enough for monitoring disease. So moving on to the second case, this is a 38-year-old female, chronic cough, intermittent shortness of breath, and symptoms are only present when the weather is changing. She has 2 dogs at home, no wheeze and auscultation, and the chest X-ray again here was normal. The spirometry is quite normal. The FEV1 is 82%. The ratio to FEV1 to FVC is 76%. The only thing here that was reduced was our FEF 25 to 75, which is the mid-range flows here. And I'll come back to that in a little while, what the significance of that may be. We did reversibility testing. Again, the results are similar. The reversibility to bronchodilator challenge with in the FEV1 was suboptimal, only about 6%. But the clinical suspicion was high for asthma. So what should we do next? And in this case, we moved on to doing a bronchial provocation test. So I'm going to talk a little bit about what bronchial provocation tests are and where they are needed. So why do a bronchial provocation test? In this case, a methacholine challenge test. We recently looked at our own data of all the methacholine challenges in patients whose spirometry at the time of presentation was not obstructive, and the patients had symptoms suggestive of asthma. And we found more than 496 such methacholine challenges, and we found that 38% of those were actually positive. So where your index of suspicion is high, but the spirometry is non-obstructive, there is good point for either doing a treatment challenge if the bronchial provocation test is not available, or moving on to doing a challenge test. There are various different stimuli that are available and that have been used over the years for doing bronchial provocation testing. There are direct stimuli like methacholine and histamine. There are indirect stimuli like exercise, hyperventilation, mannitol, hypertonic saline, and many others. In most cases, and in most places I've worked, the direct stimuli are preferred. They are easier to use and a little bit quicker to do the test as well. What do most people use? This is now a very old study which looked at 94 teaching centers in the US and looking at the questionnaire results of what people use. Methacholine was the commonest one at the time, 63%, histamine about 17%. Now, no one uses histamine because the adverse events were significantly high with using histamine. So we can merge them all into one. About 8% of the centers were using exercise as a stimulus, and about 5% of the centers were using specific antigens. Now, specific antigens are only used in research units or in occupational lung units where you're trying to induce reaction to a certain agent that patient gets exposed to at work. So in diagnosis of asthma, there is really little role of specific antigens unless you're looking at occupational asthma. Contraindication. So the first one is for airflow limitation, FEV1 less than 60% or less than 75% if you're using exercise or hyperventilation as a challenge. This is a very relative contraindication. If you really have a need to do a provocation test, you could do it. Just know that there is a higher risk of patient either getting admitted or requiring further observation or further bronchodilation. And I'll show in the next slide that fact. The quality of spirometry is very important. So one thing I would impress, which sometimes happen in our unit as well, that no patient should be referred to bronchial provocation testing without having done spirometry first. Because if the patient cannot perform spirometry, it's a complete waste of time slot. The respiratory therapist usually will block about an hour for each provocation test. The real contraindications here are the cardiovascular. It's a test in which patient is going to do repeated forceful maneuvers, increasing intrathoracic and intracranial pressure. So if there is recent myocardial infarction or stroke within the last 3 months, that's a very strong contraindication. Uncontrolled hypertension, non-aortic aneurysm, or recent eye surgery, intracranial or intracranial pressure elevation risk, or a recent abdominal surgery, for example. Other contraindications, again, are relatively relative. So I'll just show this study, which actually looked at doing provocation testing in patients who did have significant airflow limitation of FEV1 of less than 60%. And they showed that almost all the patients had no significant adverse events. Only 4 patients out of 88 required a second dose of bronchodilator. So in other words, although it's safe, it probably is going to significantly prolong the time for your test. You may need to observe patient longer, or you may need to admit them overnight if they have a pre-existing significant airflow obstruction. Although I'm hard pressed to find significant indications for doing provocation testing in someone who already has documented airflow restriction. Medication withholding schedule for the provocation test is different for that for the reversibility testing. It's much more stringent. For especially things to know are that for antimuscarinics, for example, tiotropium, you need to stop the medication for at least a week before. And the longer acting beta 2 agonist, Indectrol, Virentrol, etc., at least 2 days before you do the testing. Otherwise, you might get results which are negative, but spuriously negative. What do we measure? So provocative dose is the dose at which there's a specific fall in the FEV1 on the PFT. And we call that PD20 because the threshold for positivity is the provocative dose at which the FEV1 falls below 20%. Now, if you have a lung function lab that's doing these, you might have noticed provocative concentration instead of provocative dose, which is what we used to do as well. But the standards have changed. The new ATS-ERS guideline in 2017 has recommended that we use provocative dose to adjust for differences in the actual dose delivered by different spirometers. So to be compliant with the guidelines, everyone should be measuring provocative dose. It does require some help from the pharmacy. Theoretically speaking, anyone who has a nebulizer and a spirometer can do a methacholine challenge, but in reality, the test standards are quite stringent, and you usually require a good spirometer which can develop a report in a certain format, a trained respiratory therapist, and some help from the pharmacy as well. This is what this patient's methacholine challenge looked like. So we can see that this is the baseline, and then each cross here is a increasing dose and a spirometry after that. And after the 5th dose, the patient's FEV1 is down to 79%. So the provocative dose here is 23.7, and then you use the guidance table to decide how bad it is. So not only you report it as a positive or a negative test, you can then stratify whether it's borderline, mild, moderate, or severe airway hyperreactivity. So this patient has moderate airway hyperreactivity. The doses here are measured in milligrams. Some centers use millimoles, in which case it will be completely different numbers. So going back to our study, one other important thing we noticed there was that the patients who were positive with methacholine challenge had very significantly reduced FEF 25 to 75, both absolute and percentage predicted ratios. When we look at all the patients, the ROC curve was not very impressive. AUC was 0.69. But when we use the regression model to create a contourgram, there's a very interesting pattern here. The numbers here are the percent of the patients who were positive in methacholine challenge. So you can see that a 20-year-old with a 60% of FEF 25 to 75% would have a significantly high likelihood of having a positive methacholine challenge versus a 60-year-old with similar kind of methacholine challenge. So it looks like the patients who are younger and have a low FEF 25 to 75% are much more likely to have a positive methacholine challenge as opposed to the older patients. We also know that the FEF 25 to 75% is associated with diagnosis of asthma in children. It is associated with having high FeNO levels and eosinophilia. So it kind of is related with the atopic respiratory disease. The cutoff for the abnormality is not really well established. We know that in patients who have asthma, the FEF 25 to 75 is usually below 65, and that's usually taken as the cutoff for the abnormality, although it's not well established in validation studies. So based on what we know at the moment, I would say in the patients who are under the age of 40 with a non-obstructive spirometry, but they have reduced FEF 25 to 75 below 65%, those we should definitely consider for either methacholine challenge test or giving them a trial of inhaled corticosteroids. A quick third case, this is a 48-year-old male patient presenting with cough and intermittent wheeze, waking up early hours of the morning with shortness of breath at least 2 to 3 times a week. Previously given inhalers from combination inhalers from another facility with good response to treatment. Patient didn't discontinue because he didn't want to take any steroids. His history was consistent with nasal congestion, but he significantly improved after having nasal polypectomy a year ago. His FeNO in the clinic was 65. So the history is very, very convincing for an atopic airway disease here. Difficult patient, the kind, I'm sure you all see these patients in the clinics who have a disease and you think you can help them. The patient was more interested in getting a report for work rather than getting treatment. So his spirometry, FEV1 is normal, but the ratio is obstructive 69%. FEF 25 to 75% is significantly low as well. And the patient didn't want to go to work. He thought his work in police was the main cause of his symptoms. Here, I gave him a peak flow meter and a diary. The idea was that he'd go to work and he'll bring home peak flow and we'll get both the diagnosis of asthma and if there is an occupational element to it, that from it. Unfortunately, the patient didn't really go to work for 2 weeks, but he did do a peak flow diary, which shows very significant diurnal variation here. The baseline is kind of between 500 to 600 in the early morning, and at night it goes up to 650 to 700, which kind of correlate with his peak flow on his spirometry as well. Gina says that more than 10% diurnal variation is consistent with diagnosis of asthma. So this is a confirmatory test here. Unfortunately, this patient didn't come back because he really was looking for a report. I think he went on to some other facility after that. So peak flow is perhaps the cheapest way to diagnose asthma. And if you're working in a clinic where you don't have access to any other pulmonary function tests, then it's the easiest way to diagnose. It's easier to perform than a spirometry because you just need to do a quick, sharp blow. It can be used for diagnosis and treatment response. And anyone who gives a trial of treatment, which is an option in the GINA guidelines, I would strongly recommend that you do it with peak flow meter and a diary. You can ask patient to do their peak flow for 5 to 7 days without starting the treatment, and then start their treatment, and you can see a clear treatment response along with a diagnosis as well. It can be used to monitor the control at home. So it's usually a very good adjunct to any patient who's using to monitor his disease at home. The patients who are adjusting their medication themselves at home, which happens a lot in the UK. We have very few patients who do that here. It can be used to diagnose the occupational asthma. In fact, it is quite a cheap way to diagnose occupational asthma. The cons are that it requires discipline on the part of the patient to use it twice a day at the same time, early morning and in the night, and then record it on a diary. And there is some delay in establishing the diagnosis. So with the spirometry, you can tell them on the day that it's consistent with asthma. With the peak flow, you have to wait maybe a couple of weeks when they come back. Fractional exhaled nitric oxide. I've shown here two pictures, the two systems that are available commercially on the market. The left is the bed font and the right is the Niox Vero. And we have used both of these in our clinic recently. What does ATS say about use of the pheno? The units we measure for the pheno are parts per billion, less than 25. Eosinophilic inflammation and responsiveness to ICS and post-bronchodilator FEV1 are unlikely. If it's more than 50, then eosinophilic inflammation and responsiveness to the inhaled corticosteroids is quite likely. And in between is the indeterminate zone. Unfortunately, a lot of patients fall in that zone. So that's another quick test. It's easy to do. It doesn't require any forceful maneuvers. It does require inhalation at a certain rate, which the machines usually guide you at. So according to ATS, the minimum clinically important difference of the pheno value is defined as a difference of larger than 20% for the values above 50, or more than 10 for the values below 50. Reduction of an elevated, a reduction of elevated pheno for more than 20% often occurs in 2 to 6 weeks after initiation of inflammatory therapy, supports that the treatment was successful in reduction of inflammation. So you can use it for monitoring the response to the treatment. What does Gina say about pheno? In non-smoking patients, again, pheno above 50 is associated with good short-term response to steroids and lung function. There are no studies examining the long-term safety of withholding ICS if initial pheno is low. Now, this is very important. It's not saying you cannot reduce the steroid treatment if their pheno is good. So if someone was on high-dose steroids, the pheno comes down, you can reduce the treatment. It's just saying don't withdraw steroids completely based on the pheno values. In patients with a suspected diagnosis of asthma, pheno can support the decision to start ICS, but cannot safely be recommended for deciding against treatment. So same kind of point as before. And lastly, in children, the pheno-guided treatment was associated with significantly fewer exacerbations. Unfortunately, adults, that wasn't shown. So at the moment, Gina says further studies are needed to identify the populations most likely to benefit and the optimal frequency of monitoring. So it's not a diagnostic tool at the moment, but it can support your suspicion for the diagnosis and to the decision to start the treatment. And you can use it to up or down titrate the treatment. Just don't use it to not give any steroids or remove them completely. Just the last slide about impulse oscillometry. I have no experience of using the impulse oscillometry myself. It's mostly used in the pediatric units or in research, mainly because it's the easiest test to do. It only requires tidal breathing. It can differentiate between obstructive and restrictive diseases. There are normal reference values available from pediatrics all the way up to the age of 80. Unfortunately, there are still no reference ranges available for disease conditions. So we don't know where the line lies between the obstructive or the restrictive. You can look at the graph visually and kind of guess. But in pediatrics, it's a very easy test to do. So I'll conclude here. by saying that spirometry with reversibility is widely available now and should be used in clinical hospital settings to confirm the diagnosis of asthma, where clinical suspicion is high, but spiro is normal. Bronchial provocation testing can be used for clarifying the diagnosis. The PEFR is cheap and easy test and should be used if spirometry is not readily available, and also most useful test where occupational asthma is suspected. PINO can be helpful in titrating the treatment, can be an aid to diagnosis, but not a diagnostic test itself. And the role of impulse oscillometry remains unclear at present, but if available, can be an adjunct to the PFTs and likely to be helpful for patients who have difficulty in doing the PFTs themselves. And I'd like to thank you for your attention.